The next panel is on health-literate digital design and strategies. We have three presenters on this panel which will address designing health IT with health literacy principles in mind. The presentations will be followed by a reactor session where experts from nonprofit institution, industry, and the federal government will provide feedback on the presentations and how the information from those presentations have the potential to impact their work. The first panel will be moderated by Roundtable and Planning Committee member Suzanne Bakken. Suzanne, welcome again. Dr. Bakken is a professor at the Columbia University School of Nursing. She will briefly introduce each speaker, and of course you may read more about those in the handouts. Susan?
Thank you. It's my great pleasure to be here and to introduce the panel. On a daily basis, I work with a vibrant Latino community in Washington Heights, which doesn't remotely resemble the tech-savvy individuals that Ted was talking about in his talk. And so I think one of the important things is we really, health literacy isn't something that's assessed at the end of the design process or that you tap on. You really need to think about health literacy from the beginning of the process. And that was really the motivation of having this particular panel in which we could really hear from experts about how does one build health literacy into design from the beginning. And we really wanted to think about it from different types of consumer-facing technologies. Rebecca Schnall will start us out. She's an assistant professor at the Columbia School of Nursing and will focus more on apps. We also have Reed Holman, who's from the Health and Human Services, where he's a special advisor on initiatives related to health literacy. And then we'll also have Alex Christ, who's an associate professor of medicine and family health. I might have not got that not quite exactly right. But one of the important things is as we look at these three presentations is they really are talking about different types of consumer health-facing technologies. And one of the ideas in having Alex in his particular topic is that because of meaningful use criteria, patient portals are one of the ways that we are having communication between the patients and providers, which are a number of concerns that were brought up in the earlier discussion. So we're going to have each of the speakers do their presentation. We'll also have a reactor panel, which will follow. We'll have some timekeeping here to make sure we stick on time. Thank you so much for that. And with that, Dr. Schnall.
Hi, everyone. Good morning. So I'm going to talk today about design specifications for apps. It's a case study, and it's a very different perspective, I think, than what we've spoken about so far in thinking about this really from the front end and how we speak to our end users before we build the app, as opposed to throwing out all the apps into the App Store and then having people pick them up and seeing if it's changing behavior afterwards. So I think many of us know that there is a lot of promise to mobile health technology. Unfortunately, we still don't have a lot of research evidence, data at this point to really support how this can change behavior, health behavior, and how this can change health outcomes in a meaningful way, certainly in the long term. And that said, I think that the design of the mHealth tools, of whether we narrow it to mobile health technology, we think about it in terms more broadly of patient portals, but again, thinking more about who are our end users from the beginning. And as I said, there are, I think the estimates are about 40,000 health apps, so specifically focused on health-related activities, health outcomes, and that number changes, although as quickly as new apps come out onto the market, your teenagers, if you have any, are building their apps in your garage, and those are also coming off the market. So our number's staying about 40,000. But these apps, again, are not involving end users. So the goal of our work that we did was to use rigorous user-centered design methods to understand the needs of a mobile app for HIV prevention in high-risk MSM, so high-risk men who have sex with men. And this was the framework that we used to guide our work. This is from design science, so something that many in healthcare, many in even in informatics are less familiar with. So I just want to spend a little bit of time walking you through this framework. There's 3 cycles, and they're iterative cycles, and they're not linear. So when this was, again, the framework that guided the work that we did, and when you think about, again, these 40,000 mobile health apps, or when we think about many of the health information technology systems that we build and design today, we don't really take certainly all 3 of these important areas into consideration. But sometimes we don't even take any of them into consideration. So first, thinking about the environment, and we conducted activities centering really around what are our end users' environment, who are the people, organizations. So in our case, we weren't looking at a healthcare system, but we were looking at people in the community. So what were the environmental factors that were necessary for us to be able to tap into our participants' health information needs? And I'll detail more what we did during this relevance cycle, but we largely used focus groups with our end users. Following this, we wanted to look at what's the existing knowledge base. So again, thinking about this as an iterative process, and even though it's presented linearly. So thinking about the knowledge base, what are the scientific theories and methods? So what's already out there that has been used for HIV prevention? What are some of the experiences, some of the expertise in this field, and what already exists, right? So we know that there's 40,000 health apps in HIV prevention. There's a few hundred, actually, not thousands that we're talking about. But what is already out there, and how can we use that to inform our future design? And then finally, coming together using this relevance information and this rigor information to actually design an app, and to design the app and then also evaluate that app, which I think is also missing even after we collect the information, or even after we build the app, then we just put it on the marketplace, and we don't really think about how our end user is able to use the system. So our study population were men who have sex with men, and our study was funded by the CDC. But just to put this all in context, so currently there are about 1.2 million Americans living with HIV, and that number has stayed about the same. But the number of new infections has dramatically and continues to increase in this subpopulation of men who have sex with men, and this it has disproportionately affected young men of color, so Latinos and African Americans who are around the ages between 13 and 24 years old. Some of the estimates are as high as 29-year-olds who, again, we're kind of seeing this flat line. I don't have the picture here, where HIV is staying the same, and then just in these young MSM, the disease just continues to affect them. So we're aware that we need an app, we need something to target this population. And, time won't allow, but it's a compelling argument that we know that young adults are using apps. Everyone has a smartphone, especially young kids. Even in many of our participants were low socioeconomic groups, but even so, our kids, our adolescents, they have their smartphone. They're not really sure where they're getting their next lunch, where they're going to sleep tonight, but they all have a smartphone. So mobile health technology is an appropriate venue for us being able to deliver this health information to them, but how are we able to communicate this best to them? So our first cycle was this Relevance cycle, as I had shown you before in the illustration of the framework, and we conducted a series of focus groups. We did 5 focus groups with 33 MSM across the 5 focus groups. And we had a pretty large age range, as you can see, between 13 and 64 years old. Our focus groups were comprised of white, African American, and Latinos, although one of our groups was only Spanish speakers and one of our groups was only Latinos. So we really wanted to tap into what are some of the end user needs, particularly in these groups that are most affected. And we did a thematic analysis of our focus group sessions, and we saw that there were 5 broad categories of what these participants really wanted in their apps. So they wanted my information management. They wanted to be able to manage their own health information. So when was it that I got my last HIV test? When did I get last tested for STIs? When did I just go for my last physical? Staying healthy, they wanted information on diet, fitness, exercise, just like the rest of us are talking about. That was very relevant to their lives. And our participants wanted information on HIV testing. And then our participants talked about a chat and communication function so that they could chat and communicate between themselves and then also between some kind of health counselor, some kind of healthcare provider. And then finally, resources. So following this process and this thematic analysis where we had these 5 broad categories of what the functionality and information needs were of our participants, we conducted activities related to the Rigor cycle. And this was an environmental scan of the existing artifacts as well as literature related to both mobile health interventions and also e-health interventions. So we published a systematic review of existing e-health intervention studies that have been used with high-risk MSM targeting HIV prevention behaviors. And we wanted to have an idea, so what are the existing apps and have any of those apps been studied? And of the studies that we did include in our systematic review, there have been no rigorous studies of health interventions in this study population. And then our final cycle was the design cycle, which was comprised of 2 components, both the develop, where we actually, the develop build, as well as the evaluate cycle, which I'll talk about a little bit later. But our develop build, we had activities centered on the creation of a highly usable artifact, again, incorporating the needs of the end users, which I'll detail in the next slide. And these were user-centered participatory design session activities. So we actually had the end users very much involved. And we had a total of 2 design sessions with the same group of 6 participants. So we had our participants come in for about 90 minutes into our office, and we asked 6 MSM, they were between the ages of 20 and 25, to come in and to tell us, so these are the 5 broad categories that you identified during our previous focus group sessions. What do you want this app to look like? So we detailed these categories, again, my information management, staying healthy, HIV testing, chat communication, and then finally resources. Okay, and so I'll give you some examples of things that our participants talked about. So for my information management, so our participants talked about they wanted a log of past partners. So again, things that I think that us as maybe researchers, and some people's eyes are, I'm getting quite large in the audience right now. But these were the health information needs, again, that our participants as end users talked about that they wanted. They said that, I want to know if I test positive at a later date that I can then track back who was my past partner so that I can communicate to them that I'm now positive if I choose to do so. In terms of HIV testing, our participants had really novel and innovative suggestions of things that they needed. So when we talk about, again, everyone knows that you need to exercise. So all of our high-risk participants, they know that you need to get tested for HIV. But they had a lot of deeper health information needs as well as functionality that they wanted for their app that were things that we wouldn't have thought of ourselves as researchers. So they talked about, I want HIV testing site info. So I want to know, I want a GPS location of how to get to the site. I want other users' ratings of that site. So I went to that HIV testing site, and the people were really nice there. I want to know what the waiting times are when I go to that site. I want to know the difference between anonymous and confidential testing. So those are just some examples of some of the higher level information needs and functionality that our participants really talked about needing. Following those, that design session and gathering that information that was all recorded, we coded that. And then we had a second design session where we wanted to think more about the user interface. So what was the look and feel that you wanted this app to look like? This lasted about 2 hours, and we had our participants actually participate and stand up and draw pictures of what this app user interface was going to look like. So before we did that, we gave them examples. So these are the existing artifacts. These are the existing apps of HIV testing sites, and what do you want your app to look like? We again had 6 participants in the group, and we divided them into groups of 3, and it kind of made for a nice little competition that they sort of set up between themselves of which group was going to design the nicer user interface. And these were some of the examples of the post-it screens of how they just drew and listed what it was that they wanted. Following, we then used those whiteboards and audio recordings, and we created mock-ups in PowerPoint of what our end users thought that this app should look like for, again, HIV prevention needs in high-risk MSM. And this was our version 1 of that. It informed the creation of the map of the screen order and a low-fidelity prototype. And then following our development of these prototypes, which were low-end PowerPoint prototypes, we conducted 2 types of usability assessments, both a heuristic evaluation and end-user usability testing. So heuristic evaluation with informaticians, people who have expertise in user interface design, in usability, principles, errors, things of that nature, and then also end users. So who were these people who were actually going to be using the app in the end? And we had a total of 5 versions of the mock-up. And we had developed use cases to ask our participants to go through these steps using this mock-up, these mock-ups that we gave them. And following the heuristic evaluations, which we had with 5 experts, again, in user interface, we made 112 changes. So we had 5 iterations of our mock-ups, and we had these 112 changes. And these were some examples that I don't have time to go through, but and then we also did end user usability testing, and we had 55 changes. So we had, and our end users were both smartphone users and were not smartphone users, which was really important. And we learned different things, obviously, from different participants. And this is was our final version. It would be nice if I had them side by side to compare, but I think if you look at the SUD report, for example, that is most different. You can see the most remarkable changes where we have different color coding between negative and positive, just the overall look and feel, of how that changed. So, I kind of walked you through as quickly as time allowed our process of iterating through a mobile app, really largely using end users' needs. So again, we had our research team that was commenting and analyzing as we went through all this design process, but we also included our end users at every stage of the process and thinking then again about what our end product would be. Thank you.